Welcome to Policy and Regulation in Substance Use Disorders Care. My name is Kate Marshall. Before we get started, I just want to say that I have no financial relationships to disclose, no conflicts of interest. Opinions and guidance here are my own and don't represent any particular organization or entity. The cases have been modified and fictitious names used, and this talk does include historic materials containing racist language and imagery. Let's go over our objectives for today. So, by the end of the session, I hope you'll be able to describe the legal status of controlled substances in the United States. We'll talk about the influence of racism on the current legal status of those substances and the penalties for controlled substance use. We'll talk about levels of clinical care available for patients with substance use disorders, and identify a tool used to determine medical necessity and level of care. Finally, we'll talk about some benefits and drawbacks of urine drug testing in patients with substance use disorders. Now, as you can see, there are a few disparate topics in policy, regulation, systems of care, as well as inequities to address today. Hopefully, as we move forward, you'll get a sense of how we got where we are today and what options are available for our patients. Let's start with a case. This is Michael, a 57-year-old mail carrier with a history of hypertension and chronic low back pain, with intermittent prescription opioid use, who was seen in primary care for routine follow-up. On his screening form, he indicated he's been drinking alcohol daily. On further questioning, he said he's been having up to 8 drinks each night to help with his back pain. He says, "I'd rather smoke a joint than drink that much, but if I get drug tested at work, it would get me fired, so I stick to the legal stuff." Now, as I weighed the potential risks and benefits of chronic prescription opioids, daily heavy alcohol use, and daily cannabis use, I considered the regulation around each option and the historic forces that have shaped which centrally acting substances are acceptable or unacceptable to the general public. Now, with that in mind, today we're going to talk a bit about the current legal status of substances and controlled medications, as well as how we got there. So, historically, centrally acting substances are controlled in one of two general ways by the U.S. government. So, some substances are permitted but regulated and taxed, as in the case of alcohol and tobacco. Now, control of alcohol and tobacco fall under the jurisdiction of the Bureau of Alcohol, Tobacco, Firearms, and Explosives. This bureau has actually moved between the Department of the Treasury and the Department of Justice several times since the bureau's inception in the late 1700s. Its current home is under the Department of Justice, which happened in 2003 with the Homeland Security Act. On top of the controls laid out by federal policy and enforced by federal officials in the ATF, alcohol and tobacco are subject to additional regulation by state-level agencies and enforcers and tax laws, which is why you may see state-to-state differences in the cost and availability of alcohol and tobacco. The other main agency controlling substances in the United States is the Drug Enforcement Administration, or DEA. Now, this agency has been under the control of the Department of Justice since its inception in 1973, when it replaced the Federal Bureau of Narcotics and brought most federal regulation on substances other than alcohol and tobacco together under just one roof. The task of the DEA is to enforce the drug schedule, a list of substances created in 1972 by the Controlled Substances Act. States may also decide to add additional regulation onto these substances or choose their own penalties for violation of the schedule, which is why you may see differences state to state in the way these substances are handled. And since we as physicians need to interact with the drug schedule and know our role in it, let's spend some time looking at how it works. Under the DEA's drug schedule, substances are classified from Schedule 1 to Schedule 5. Schedule 1 substances are the most controlled, and Schedule 5 are the least. Substances in Schedule 1 cannot be prescribed by medical providers under any circumstances, and researchers must obtain special permission to study them. And while many newly synthesized substances have been added and a few moved up or down on the schedule since 1972, for the most part, the actual schedule has remained fairly static for the last 50 years. So what's in Schedule 1? According to the DEA, Schedule 1 consists of drugs with no currently accepted medical use and high potential for abuse. Examples of substances in Schedule 1 are heroin, cannabis, LSD, MDMA, peyote, psilocybin, and fentanyl analogs that aren't in current medical use. Schedule 2 consists of drugs with a high potential for abuse, with use potentially leading to severe psychological or physical dependence. Oxycodone, morphine, fentanyl, methadone, and indeed most opioids in current medical use are in Schedule 2, as well as cocaine, methamphetamine, methylphenidate, and others. One notable change in Schedule 2 over the years is that buprenorphine was actually moved out of Schedule 2 all the way down to Schedule 5 in 1985, but then back up to Schedule 3 when a new law permitting its use as a treatment for opioid use disorder was passed in 2002. Another important change is that opioid antagonists such as naloxone and naltrexone were initially Schedule 2, but were removed from the schedule in the mid-1970s. Schedule 3 consists of drugs with a moderate to low potential for physical and psychological dependence, and includes anabolic steroids, testosterone, ketamine, and buprenorphine. Schedule 4 is drugs with a low potential for abuse and low risk of dependence. Benzodiazepines, sedative hypnotic Z drugs, and tramadol are in Schedule 4. Benzodiazepines emerged in the 1980s and were placed into Schedule 4 alongside barbiturates, which they have now largely replaced. In subsequent years, a few select barbiturates have actually been moved up into Schedule 2 and 3 over the years as their dangers have become more apparent. Schedule 5 is drugs with lower potential for abuse than Schedule 4, but that are still controlled. This would include cough medicine with codeine, Lomotil, and pregabalin. As we look at the drug schedule, it's interesting to note that some substances that we might consider to be low risk for dependence, for causing harm to oneself or harm to others, are scheduled quite high. For example, here we see a scientific consensus around the relative harms of some of these substances, and while it agrees with the schedule in some instances, in others it's pretty much the opposite. So it's really in Schedule 1 that the rubber hits the road and people start to ask why these substances are federally banned. With some of these, individual states have gone so far as to buck federal policy and completely decriminalize their possession and use. At this point, I think it's important to recognize that, especially when it comes to the most forbidden substances, the Controlled Substances Act was based partly on the views and priorities of the administration in 1972, and partly on policies that had already been put in place before the act was written. And really, those views, priorities, and policies were largely not based on medical fact or actual risk, but on social and economic forces occurring at the time. As David F. Musto, drug policy expert and advisor under President Carter, put it, the American concern with narcotics is more than a medical or legal problem. It is in the fullest sense a political problem. The energy that has given impetus to drug control and prohibition came from profound tensions among socioeconomic groups, ethnic minorities, and generations. The most passionate support for legal prohibition of narcotics has been associated with fear of a given drug's effect on a specific minority. Certain drugs were dreaded because they seemed to undermine essential social restrictions which kept these groups under control. Legal prohibition of drugs for non-medical purposes seems to come at a time of social crisis between the drug-linked group and the rest of American society. And indeed, when we look at the evidence heard by the U.S. government in favor of regulating these substances, there is a strong through line of xenophobia and racism. Opium and heroin were among the earliest banned substances, largely driven by their association with Chinese immigrants. Policy discussions strongly intertwined Chinese culture with opium use, and types of opium specifically used by Chinese immigrants were the first to be banned. In 1902, the American Pharmaceutical Association concluded in its report on opium use that, if the Chinaman cannot get along without his dope, we can get along without him. In the 1910s, the U.S. government became interested in regulating cocaine due to its association with black men in the South. One U.S. government report concluded in favor of banning the substance by saying, "It has been authoritatively stated that cocaine is often the direct incentive to the crime of rape by the Negroes." In the 1930s, cannabis was strongly associated with both jazz culture and with Spanish-speaking residents of the American Southwest. The U.S. Secretary of the Treasury heard from constituents who reported to him, "I wish I could show you what a small marijuana cigarette can do to one of our degenerate Spanish-speaking residents. That's why our problem is so great. The greatest percentage of our population is composed of Spanish-speaking persons, most of whom are low mentally, because of social and racial conditions. Through representatives of civic leaders and law officers of the San Luis Valley, I have been asked to write to you for help." 1 year later, cannabis was taxed to the point of illegality on the federal level by the Marijuana Tax Act of 1937. The association of minority groups with drug use and violence continued through the 1960s and 1970s, though less explicitly by then. Speaking in 1994, John Ehrlichman, former policy advisor to Richard Nixon, was frank about the intentions behind the 1972 Controlled Substances Act and Nixon's declaration of drugs as public enemy number one. The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or black, but getting the public to associate the hippies with marijuana and blacks with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Now, it's one thing to acknowledge that many substances have no accepted medical use, but it turns out that substances in higher schedules also have higher penalties associated with their sale and possession than lower scheduled substances. You can see here that the federal guidelines for penalties associated with substances are grouped by schedule. So this historical precedent of racism and alarmism around substances, in conjunction with other components of systemic racism on the enforcement side, has actually resulted in a deep and pervasive racial divide in drug enforcement. For example, you can see here that while most crack cocaine users are white, the vast majority of defendants are African American. And while it's our job as physicians to respect and abide by the drug schedule, it behooves us to consider the actual risks and harms of substances as we counsel our patients, and to understand how a century of drug policy has in many cases become a critical social determinant of health. Another important aspect of drug control that we need to understand is additional limitations on the use of opioids to treat opioid use disorder. We saw methadone in Schedule 2 and buprenorphine in Schedule 3, but you're probably already aware that there are additional layers of regulation around these. At this point, let's go ahead and dig into that additional regulation and what it means for your practice. The most important fact to know is that back in 1919, the United States made it illegal for physicians to prescribe opioids solely to maintain a patient's opioid dependence. Opioids can be prescribed for treating pain, obviously, but not to prevent withdrawal or maintain a dependence in the outpatient setting. And this rule does not apply to the hospital setting. There, opioids may be used to treat opioid dependence or withdrawal if withdrawal would complicate treatment of a medical problem. However, in the late 1960s, many U.S. soldiers were returning from Vietnam having tried heroin while deployed. At the same time, pilot programs showed that methadone could help people stay off heroin when used as a maintenance therapy. In 1974, the U.S. government then created an exception to allow the use of methadone to treat opioid use disorder, but only when it is dispensed by a federally regulated opioid treatment program and according to rules laid out in federal policy. This resulted in our current system of methadone clinics operating separately from primary care and other outpatient care. To this day, only physicians working within one of these opioid treatment programs are permitted to prescribe or dispense methadone for opioid use disorder. In the inpatient setting, Methadone has always been an option to prevent withdrawal, but still can't be prescribed or dispensed on hospital discharge, so a next-day appointment at an opioid treatment program is needed for patients to continue therapy when leaving the hospital. As more Americans became dependent on prescription opioids in the 1990s, another solution was sought. Buprenorphine, a partial agonist opioid with an excellent safety profile, showed promise as an alternative to methadone. In 2002, the government allowed another exception in allowing outpatient medical providers to prescribe buprenorphine for maintenance therapy, but required additional education and a declaration of intent to SAMHSA in order for them to do so. When these requirements are fulfilled, the DEA issues a waiver to prescribe buprenorphine. Buprenorphine can be prescribed without a waiver while a patient is admitted, but to prescribe on discharge, a provider must have that DEA waiver to write for buprenorphine to be used outpatient. Finally, in April of 2021, the need for additional education by physicians was waived in light of the unremitting opioid crisis. At this time, providers do still need to notify the DEA of their intent to prescribe buprenorphine to up to 30 concurrent patients before using buprenorphine to prevent opioid withdrawal or treat opioid use disorder. Okay, let's step back now and consider the rest of the system of care patients with substance use disorder may engage with. There are a few important general points that I'd like to cover that should help you help patients navigate a diagnosis of substance use disorder. Let's get back to Michael. I offered him brief advice to cut back on his alcohol use in the primary care appointment and saw him back a month later to check in. He reported that he had tried to cut back, but found that he developed severe anxiety and shaking hands. He has been having frequent and intrusive thoughts about drinking and reported that he had missed a few days of work due to being hungover. Based on our conversation, I diagnosed him with severe alcohol use disorder, and he asked if I thought he needed detox or rehab. It's time to talk about the spectrum of substance use disorders care. This spectrum is well laid out by the American Society of Addiction Medicine, or ASAM, in something called the ASAM Continuum. If you run an internet search for ASAM Continuum, it's easy to review. So you can see that at the low intensity end of the spectrum is prevention and early intervention. Level 1 is outpatient care, either in primary care or addiction-oriented clinics. Outpatient level support might also include individual or group therapy, medication treatment, and mutual support groups like AA. Level 2 is intensive outpatient, where the patient spends multiple hours a week in day programs. In partial hospitalization, they may also stay in associated housing not on site. Level 3 includes low-intensity residential treatment, where patients stay on site and attend groups and activities pretty much all day. This is what most people mean when they say rehab. Level 3 also includes higher levels of care, like medically managed withdrawal, where patients get nursing assessments, medications, and vital sign monitoring, what most people would call detox. Level 4 is hospitalization in a traditional hospital. Now, how to match a patient with the right level of care? ASAM has another nice framework called the ASAM criteria. There are 6 dimensions to consider, from the medical risk of withdrawal to readiness to change to available social support. A behavioral health specialist sits down with the patient and determines how they score on each dimension and what level of care is right for them. Assessment using the ASAM criteria is considered the best measure of medical necessity for insurance purposes, and in many states is required to determine placement, so it's good to at least be aware of it. The nice thing is that it tends to align well with our clinical judgment and instincts. If you're thinking to yourself, I can't handle this, I think this patient needs to have their withdrawal managed in a specialty setting, then you're right, and the patient will easily score for a 3.7. On the other hand, if the patient has low likelihood of physical withdrawal and have never attempted to disrupt their use under outpatient care, they probably won't score high enough to qualify for a residential program. But that makes sense, right? I referred Michael to medically managed withdrawal, and he was able to safely withdraw from alcohol in a supervised setting. When I saw him back in the office several weeks later, he reported that he had not returned to alcohol use, but that his back was really acting up, and he would like a refill of his small supply of low-dose oxycodone, which he usually reserved for breakthrough pain. As I considered whether to approve the refill,
I also contemplated the role of urine drug testing in the care of patients with substance use disorders. Urine drug testing has long been considered a critical component of the care of patients with substance use disorders, to the point where it's almost a vital sign of sorts. Many insurers and health systems lay out rules for frequency of urine drug testing in patients on chronic opioids or receiving treatment for substance use disorders. Some insurance plans use the results of urine drug testing to approve or deny ongoing reimbursement for medication treatments for substance use disorders. I'd like to offer a word of caution in the use of urine drug testing in patients with substance use disorders. First, it's important to realize that the act of obtaining a urine drug test and how the results of the test are used is fraught with both implicit and explicit bias. For example, Black women and their newborns are 1.5 times more likely to be tested for non-prescribed drugs at delivery than other groups. Among patients on long-term opioid therapy, Black patients are 3.3 times more likely to have their opioid therapy discontinued if they test positive for cocaine. These are just a few of many examples of how drug tests can foster inequity in care, especially if we are not conscious of our own potential biases in their use. That said, urine drug tests have the potential to be an important tool, mostly because they can help you understand if your patient is struggling with ongoing use, and that the patient might need more attention or care. But false positives definitely occur on these, and many addiction providers would advise you never to act on a screening test without quantitative confirmatory testing. And even then, they'd advise you not to base your treatment entirely on the results of that test. It's one part of what's going on with the patient, but it's not the whole story. In future talks, we'll get into a bit more detail about false positives, false negatives, and how to use urine drug testing to support a plan that works for the patient. I have no doubt that you'll encounter many, many patients like Michael in your medical career. I hope that what we've discussed today will be helpful as you consider the many policies, regulations, social forces, economic forces, and historic biases that have brought the United States to its current state with regard to substance use and control. And, as you consider the patient in front of you, I hope you will have a better understanding of how our system of care can work for and with them. Thank you.